Kennedy, Malone, and colleagues defined geriatric syndrome as a term used to describe common health conditions shared among older adults. Oftentimes, these conditions do not fit into distinct system-based disease categories and are frequently multifactorial in nature. Furthermore, geriatric syndromes have a major impact on the quality of life and disability of older adults. Among these geriatric syndromes, falls are a leading cause of injury, disability, loss of independence, nursing home placement, and even death among the elderly population. Falls are defined as an unintentional descent to the floor or another level with or without injury. Falls may also include near falls, such as slips or trips, and can even include a broken fall, where a caregiver or the individual decreases the impact or the intensity of the fall. Falls result from a combination of intrinsic and extrinsic factors: advanced age, female gender, age-related changes, and chronic medical conditions, particularly arthritis, dementia, depression, and heart disease. These conditions, combined with environmental factors, make older adults extremely vulnerable to falls. Furthermore, a history of falls is the single greatest predictor of future falls. These individuals have a 60% risk for future falls with subsequent loss of independence. Every year in the United States, 1 out of every 3 individuals over the age of 65 will fall, and that rate is doubled for those living in residential care. Likewise, the incidence of falls increases to 50% in individuals 80 and over. Falls attribute to 62% of emergency room visits, and nearly 10% require prolonged hospitalizations. And while hip fracture is the most feared consequence of falling, falls commonly result in wrist, humerus, compression fractures, along with soft tissue injuries. However, 95% of hip fractures are related to falls, and 25 to 75% of patients never regain pre-functional status. Countless conditions predispose older adults to falls. However, research shows that many fall-related injuries can be prevented by altering modifiable risk factors. The nurse practitioner can identify risk by performing a comprehensive geriatric assessment, including a medication analysis. When risks are identified, the NP should implement a multifactorial plan aimed at reducing risk. Exercise, even in frail individuals, is shown to reduce falls by improving muscle strength and joint stability. A home checklist should also be completed to identify potential home hazards that increase fall risk. The patient is a 67-year-old Caucasian female who presented for evaluation of response to antidepressant treatment. She is a retired nurse with optimal health literacy. The patient has a long history of generalized anxiety disorder with a recent diagnosis of late-life unipolar depression. Because her physical and psychological health are inextricably related, a comprehensive geriatric assessment was performed. Apart from her colonoscopy, which she verbalizes fear of undergoing despite her husband's recent death from colorectal cancer, the patient is current on all recommended primary and secondary preventative health. However, she has had negative FOBT and FIT screenings. Her AFib is managed by her cardiologist. However, she reports missing her last appointment while caring for her late spouse. A follow-up was made during this encounter. The patient manages her own transportation, finances, and medications. She denies difficulty performing daily activity. She does not smoke, drink, or use illicit drugs. The clinical presentation of problems with falling or risk of falling is varied because falls are caused by a combination of several risk factors. Patients at a greater risk of falling may present with complaints of being unsteady or may verbalize a fear of falling or a decline in their mobility or lower extremity weakness. They may also report changes in memory or confusion, dizziness, poor coordination, changes in vision or hearing, or may report a recent fall. Patients at risk for falling may also present with an acute illness such as a respiratory or urinary tract infection, dehydration, or delirium. Each are known to increase the risk of falls. The patient denied fever, fatigue, unintended weight loss, changes in sleep pattern, hearing or vision changes, vertigo, tinnitus. She denied cough, wheeze, shortness of breath, palpitations, postural hypotension, swelling in her extremities, claudication, or leg cramps. She denied urinary symptoms, muscle weakness, or joint pain. lightheadedness, focal weakness, numbness, tingling, gait instability, poor coordination, or a decline in her memory. She is positive for a history of depression, anxiety, hypertension, and AFib. These conditions and their treatment increase her fall risk. The patient was a well nourished, well developed, high functioning older adult female. She was alert and oriented and in no acute distress. However, her blood pressure on intake was elevated due to her anxiety in a medical environment, but a manual was rechecked at the end of the visit with noted improvement. Apart from her atrial fibrillation, her physical exam was unremarkable, as were the results of her utilized tools. The patient scored a 28 out of 28 on her Tonetti gait and balance, which does not indicate impairments with her gait or balance. Furthermore, the patient scored a 30 on the mini mental exam, which does not suggest impairment in cognition or short term memory. Because she was here for depression follow up, she was re-screened with the geriatric depression scale with an improved score of 2 compared to a previous score of 7 prior to her depression treatment. A home checklist was also completed, which indicated her home is currently free from hazards that could increase her risk for fall or jeopardize her health or independence. There are no specific diagnostic tests or labs to evaluate for fall risk. However, individuals may benefit from testing that would identify infection, dehydration, anemia, or low vitamin D, or other conditions like diabetes known to increase the risk for falls. The patient did not have labs obtained during this encounter. However, labs from a recent encounter were reviewed. All of her labs were normal except for her lipid panel. She is currently on lipid lowering agents and has been advised on lifestyle and diet modifications to help lower her cholesterol. The goal of therapy for individuals who are at high risk for falls is aimed at fall prevention. If risks are identified, the most effective strategy in preventing falls is addressing multiple factors. Evidence suggests that interventions must be individually tailored to target identified risk. Interventions or strategies known to decrease the risk for falls include minimizing medications, exercise in the home or in a group setting. Exercise should also emphasize on balance and resistance training like Tai Chi, and individuals must progressively increase the intensity of their training. The patient is walking daily, but she was instructed to increase the intensity of her regimen. Medication modification is another way to decrease fall risk. During this encounter, we initiated a taper of the patient's Xanax and ranitidine. Other interventions to decrease falls include a home safety evaluation, which was performed, modify the home environment, treat chronic conditions known to increase fall risk, manage footwear, and provide patient education. There are countless differentials for the geriatric syndrome falls. Child and colleagues reported that 80% of falls are related to sensory neural deficits, 10% are related to syncope, and the other 10% are caused by acute illnesses such as pneumonia, stroke, anemia, or dehydration. Differentials are excluded based on the patient's clinical presentation, review of systems, physical exam findings, and the results of screening tools and diagnostic and lab findings. The patient's differentials included adjustment disorder with mixed anxiety and depression, typical atrial flutter, and at risk for environmental injury. I included atrial flutter as a differential because in atrial fib, the R-to-R interval does not follow a repetitive pattern. Thus, the common finding is an irregularly irregular rhythm. During the exam, I noted a very regular irregular rhythm that is more characteristic of atrial flutter. The differential was excluded because the office does not have access to an EKG machine. The patient's final diagnosis of depression, anxiety, hypertension, atrial fib, and polypharmacy directly increase her risk for falls. The medications used to treat these chronic conditions further increase her risk, including lisinopril, atenolol, sertraline, and Xanax. The patient reported improved anxiety symptoms since the initiation of sertraline, which led to a tapering off of her Xanax. Polypharmacy was included because the patient is on more than 5 medications and the medication revealed inappropriate and unnecessary medication. Atrial fib was included due to her known history and its association with fall risk. Dyslipidemia was included because of her known history and recent labs revealed persistent elevations in her cholesterol levels. The patient also received her flu vaccine during this encounter. Although prevention can be successful, there are a number of barriers to implementing strategies to reduce falls. Challenges include the cost of exercise classes such as Tai Chi or aerobics and other facility fees. Transportation can also be a barrier if the patient no longer drives and relies on others or public transportation. Poor access to available interventions, or perceived lack of time. Many older adults resist using walking aids or other assistive devices because they view them as a symbol of aging or frailty. Culture can also influence whether an individual views fall preventions as positive or negative. Many are reluctant to exercise due to pain. Furthermore, a patient may not report falls out of the fear of loss of independence. To improve fall strategies, we must acknowledge the individual's personal beliefs and behaviors in order to learn what kind of changes they are willing to make in order to reduce their fall risk. Because the patient is recently widowed and has limited interactions with friends and family, she was informed of the Johnson City Senior Center. The center offers a number of activities and various exercise classes. There is no membership fee, and classes range from $2 to $5. The center plans activities and services that are designed to improve the physical, social, and emotional quality of life of local seniors. There is a wide range of healthcare providers involved in providing care to older adults, including a core team of nurses, primary care providers, social workers, physical and occupational therapists, nutritionists, pharmacists, and a wide variety of specialists, including geriatricians, who specialize in the diagnosis, treatment, and prevention of disease and disability in older adults. There has been a decline in the patient's mental and physical health since her retirement 4 years ago. After retiring, she reports a sedentary lifestyle with subsequent medical conditions and associated polypharmacy. She also reports self neglect and social isolation. Her daughter lives with her but works long hours and is, quote, rarely home. However, positive behaviors include participation in interpersonal therapy, and she verbalized the desire to resume working or volunteer as a nurse. The patient does not suffer from socioeconomic or low education levels and reports a healthy life course. However, other factors such as biology and genetics contribute to her health. She is a widowed female with a strong family history of cardiovascular disease and mental health disorders, including depression, anxiety, and Alzheimer's dementia. She repeatedly expressed fears of mental decline. In order to achieve optimal health, each of the social determinants of health must be addressed. As with many geriatric syndromes, falls typically occur when there are impairments in multiple domains that compromise physical and cognitive ability. Falls, or the risk of falls, can go unnoticed for a variety of reasons. The provider may not ask about the history of falls, or the patient may not report falls, or the individual may believe that falls are just a normal part of aging. Falls are the cause of significant morbidity and mortality in older adults and a major factor threatening their independence. The importance of falls is emphasized in a study that reported 80% of women would prefer death than a fall that would place them in a nursing home. When caring for older adults, we must routinely inquire about falls, assess for fall risk, and address modifiable risk factors to prevent falls.